Well, hello, everyone. I'm Dennis Stone, Director of the Center for Advocacy and Social Justice at the Jacksonville Urban League. And this is a part of a series of maternal health. And we're very pleased to have Dr. Ahmad Hassan with us to talk about um, issues related to that. And I'm going to turn it over to Dr. Walid Zaur, who is an intern at the center. And also, I did want to recognize Sadia Barge, our coordinator, who helps make all these meetings possible, coordinating our intern group. So with that, I will turn it over to you, Dr. Zaur.
Hello, everyone, and welcome for our series or our second in the series of maternal health town halls. Today, our topic is maternal health and chronic disease prevention. It is my pleasure to introduce our guest speaker, Dr. Ahmad Hassan. Dr. Hassan is a dedicated physician with extensive experience in pediatric medicine and has a strong commitment to improving patient outcome through prevention, early intervention, and community-centered care. His work spans across managing chronic diseases and addressing key health challenges that disproportionately affect vulnerable populations, including mothers and children. He brings a thoughtful and practical perspective on how healthcare systems and communities can work together to improve maternal health, reduce disparities, and promote long-term wellness. We are truly honored to have him with us today to share his insights and expertise. Please join me in welcoming Dr. Ahmad Hassan.
Thank you so much, Dr. Zahoor, for such a comprehensive introduction. And it is a privilege for me to be joining the Jacksonville Urban League project regarding educating the masses regarding maternal health. And by the end of this session, we will be covering a lot about the maternal health variants. Let me share my screen first. Please let me know if my screen is visible to everyone.
Yeah.
Yes, we can see it.
Okay, now I'm going to formally start. Good afternoon, everyone. It is a privilege for me to be part of this project. Now, the topic that we are going to discuss today is maternal health and chronic disease prevention. Here, what we need to understand is the impact that we usually have when the child is within the womb of the mother, and what long lasting impacts does each and everything has on both the child and the mother in the long term. We often think of health as a journey that begins at birth, but the science of the first 1,000 days basically shows something else. The research has already shown that the first 1,000 days also includes the time period that a fetus spends within the womb of the mother. So, since I am a pediatrician and I basically focus on neonatal and emergency care as well. So, there are very first hand experiences that I would like to share through this presentation and this opportunity with each and every one of you so that we can understand the impact and the long lasting problems that we can encounter if we do not have proper antenatal care. So, today we are going to be exploring a fundamental truth that we are not just delivering babies, we are quite literally shaping the generations that are to come. Now, the question is how maternal health shapes the future of the families. So, the important question here to ask is why does this matter? Because health of a mother is basically the primary architect of a family's future. The physiological state of a woman during the pregnancy, be it her mental health, be it her social health, be it her medical health. Everything basically impacts ultimately the fetus and ultimately the long term impacts that it can have on the fetus. So, the physiological state of a woman during pregnancy sets a trajectory, basically, not just for the child's infancy, but for the entire adult life, influencing the risks for chronic diseases decades down the line. So, that is why this specific session has been planned by the Jacksonville Urban League. We are going to discuss basically two parts. First, we will examine the biological mechanisms, how the maternal conditions basically alter the growing child. And secondly, we will discuss in detail the long term impact and the prevention strategies to curb this issue and ultimately lead to a healthy and healthier babies and healthier generations. Now, what I'm going to discuss here is the womb effect that I have already implied before in the first 1000 days of life bracket. The womb effect is basically the silent biological dialogue that occurs basically between a mother and her fetus. It is a period of intense programming. Once a fetus is there, then how the external environment affects the woman, and ultimately it affects and it is translated into internal biological signals that ultimately leads to different changes in the fetus. That is called the womb effect. This lecture encompasses around this womb effect, and we will be discussing the conditions that basically impact both the mother and the baby in the long term. Firstly, I'm going to share some introductory slides in which I will basically try to amalgamate the things that alter the programming within the fetus and the mother. If we look at this mechanism that is already visible to you guys, we see that maternal factors like the nutrition and stress aren't just feelings or habits. They basically cause alterations in the maternal biology. The metabolic, immune, inflammatory, and endocrine alterations. These alterations ultimately impact the fetal compartment, ultimately impacting the brain development, ultimately impacting the organ development, and also ultimately impacting each and every habit of the child. The question arises that why is this so important that the maternal environment is given prime importance? This is the main reason that if there are alterations in the maternal biology, they will ultimately impact the fetal compartment, ultimately impact the fetal cognition, the fetal brain. This will lead to the basic things that we observe in the fetus in the later life. It will impact the infant feeding, it will impact the child's diet, it will impact the child's physical activity, it will also affect the maternal parenting behavior, and also it will ultimately lead to the overall cognitive development of the child. So, if we summarize everything that I have basically told you guys so far, is that whatever impact is given to the mother, the impact shifts to the baby in the long term towards his or her cognition and ultimate adult life. This is another basically diagrammatic representation of the same thing, in which that in the first 1000 days are the most critical window in human development. The three major pillars of the first 1000 days of development are nutrition, the microbiome, and the epigenome. These three are the major determinants of the first 1000 days of life health. In nutrition, we can understand that if there are problems with the nutrition, maternal nutrition, then it will impact the baby's life. If there are problems with the neonatal and infant nutrition after the birth, there will be impacts with the uh, with the baby's life in the long term as well. Moreover, second thing, we move toward the microbiome. Microbiome is the maternal microbiota. Basically, it basically involves all the environmental pathogens that basically reside within the body of both the mother and the fetus. If that microbiome is disturbed, ultimately it will lead to problems with the baby and the mother as well, obviously. And the third thing that we are going to focus basically in this lecture is the epigenome. Epigenome includes the human genome and the environmental factors that basically makes the uh, child and mother more prone, and it is one of the things that is most easily preventable. That is why we focus on this aspect the most. Now let me move forward. Now, this is another diagrammatic representation of the same thing, but this is a little in-depth analysis. What we see here is that maternal stress, maternal anxiety, poor nutrition, and exposure to traumatic events, this leads ultimately to problems with the hypothalamic pituitary axis. This is basically a small gland within our brain called the pituitary gland. When there are problems with that gland, there will be problems with different hormones that will ultimately lead to epigenetic modifications in the placenta that basically uh, transmits each and every signal from the mother to the baby. So, a bad signal to the mother will ultimately translate into the bad signal to the baby, and it will lead to a more detrimental lifestyle and problems in the adult life of the baby as well. This is the major mechanism that is described in this slide. That is, environmental stressors are directly translated to the fetal environment, although they are being communicated to the maternal environment, but they directly impact the fetal environment. Now, this is the thing that we are going to discuss. Babies don't just inherit the genes, they inherit the environment. This is the major striking point that is the take home message that everyone from this lecture should at least understand, that the environment we provide to the mother, that is the environment we are providing to the baby, and that is the environment that we will be creating for the baby. Now we are going to discuss two major chronic conditions that we normally encounter within the communities. The first condition that we are going to discuss is hypertension in pregnancy. Every one of us know that hypertension is basically increased blood pressure, and hypertension is also known as the silent killer, as we all know. There are multiple implications of hypertension. It will affect your heart, it will affect your kidneys, it will affect your lungs, it will also affect your other organs as well, your general makeup of your health. It will also affect your aging. It will ultimately lead to chronic complications. Now, the prevalence of this hypertension in pregnancy among Black women in the US is 60% higher than among the white women. That is a very, very striking point that we need to understand. That since the prevalence of this hypertension is 60% higher in the Black woman. So this means that they need the most care. They need that their antenatal checkups are on time. It is needed that they are addressed earlier. The antenatal checkups are more comprehensive. And if there is problem with hypertension, then it must be diagnosed early, and there should be practices that things should be streamlined to encounter this problem, both in the prevention strategies and treating side as well. Now, I'm going to dig in detail in both these diseases. The hypertension in pregnancy is a very, very important thing. And first, we need to understand what are the causes and what are the risk factors for the hypertension. Who is most at risk? We see that frequently in the first pregnancy, hypertension is one of the major problems. If there is history of gestational hypertension, that is, if a mother has already gone through her first pregnancy and she had history of hypertension during her first pregnancy, there are more chances of her having hypertension in her second pregnancy as well. Third thing is twins, triplets, or multiple pregnancies. That is, if there is a singleton pregnancy, then the risk of hypertension are less as compared to twins, triplets, or multiple pregnancies, multiple gestation. If the mother has obesity, if the mother has diabetes, or if she has kidney disease that she already had, then hypertension risks spikes up. If the mother has conceived through assisted reproductive technology like IVF, there are greater chances of hypertension as compared to normal conception. Then comes the age bracket. If the mother's age is less than 20 or more than 35, then it is one of the risk factors. Family history is another risk factor. Gestational diabetes is also linked to high blood pressure. We will discuss the gestational diabetes mellitus in our next slides as well, inshallah. And autoimmune disorders like lupus or antiphospholipid syndrome is another risk factor. So if I'm going to summarize this whole slide, a mother who is less than 20 or more than 35 years of age in her first pregnancy, or with a history of gestational hypertension, with some chronic disease like kidney disease or diabetes, and if she has conceived with some assistive reproductive technology, then she is at risk of hypertension. Such cases needs detailed and frequent antenatal checkups so that it is diagnosed early. Now the question arises, okay, it needs to be diagnosed early, but how? These are the symptoms that we need to look for in the pregnancy. If there is reduced urine output, if there is sudden abnormal sweating in hands, face, or feet, if there is blurred vision, if there is sudden weight gain caused by fluid retention, if there is upper abdominal ache, primarily under the ribs on the right side, and there is lasting and severe headache, then these are the symptoms that we need to watch during the pregnancy. So anything concerning must be addressed and must be taken care of. Once hypertension is diagnosed, then we need to understand what complications it can cause both in the mother and the baby. Because Once we will understand the impacts that the hypertension can have, only then we will realize that how important is it to control hypertension? How important is it to control the blood pressure within the mother? So it will have impact both in the mother and in the baby. The hypertension in the mother can lead to placental abruption. Placental abruption basically means that the placenta starts bleeding. And once the placenta starts bleeding, basically the blood supply to the fetus gets compromised. It also can lead to mother being bled out. This is a very concerning thing that needs to be addressed. Moreover, it can also lead to a syndrome known as HELP syndrome. We won't go into the details, but you can understand it that HELP syndrome is basically a syndrome in which the platelets get lowered. It can also lead to kidney damage. It can progress to eclampsia. Eclampsia means that a mother starts having seizures. The mother starts having fits during the pregnancy, and it is very difficult to manage once the mother starts developing these seizures. And there is also high risk of stroke and cardiovascular events that includes heart attack, angina, MI, and there is also risk of developing chronic hypertension later in life. So mother is at risk once she develops hypertension during the pregnancy. She is not only impacted during the pregnancy, but once her pregnancy ends, still there are problems that persist, and she can have long-lasting impacts on her other organs as well. Now we move towards the baby. Now, once there is hypertension in the mother, what we need to understand is that placental blood flow is like a Willis, is like, you can say, a bridge. Once there is increased blood pressure in mother's vessels, it leads to compression of the vessels in the fetal vessels. Ultimately, there is less transmission of blood, there is less transmission of nutrients, and there is less excretion of metabolites from the fetus. This leads to ultimate issues with the fetus. It leads to restricted growth in the uterus, leading to babies that are smaller in size, that have basically intrauterine growth retardation, and we basically see such babies almost in our daily in our practice. A baby who is less than 2,500 gram in weight is a baby that is not who has not gained adequate weight within the uterus if the baby is delivered after 39 weeks of gestation. And chronic hypertension or hypertension in pregnancy is one of the major risk factors of having babies that are smaller in size, lesser in weight than normal ones. Another problem that can occur in the baby is preterm birth. Preterm birth means that the baby is delivered earlier than the usual 40 weeks that we have calculated via the due date. And if the baby is delivered preterm and the baby is low birth weight due to growth restriction in the uterus, this ultimately leads to multiple problems. It leads to problems with the viability of the baby. It leads to problems with the maturity of the lungs of the baby. It leads to problems with the maintenance of the temperature of the baby, and the baby may need ICU support. The baby may needs an ICU admission, and ultimately may also need surfactant administration that is needed to inflate the lungs, because the lungs maturity is the primary problem that occurs with the preterm birth and restricted growth of the baby due to hypertension. There can also be reduced amniotic fluid, that is the fluid around the baby. That is also called oligohydramnios. And it also ultimately leads to certain birth defects like limb defects, because the baby does not have a cushion to basically live into. There is increased need for NICU, neonatal intensive care, that I've already mentioned. And the worst case scenario is that the baby dies within the uterus. Due to hypertension in the mother, the baby dies. And there is a risk of the stillbirth. So you can all understand how grave this thing is and how badly it needs to be addressed. This is another representation of the same things. There is representation that mother has hypertension. The problems with the mother includes the long-term problems that include enlarged aorta, postmortem muscular structure problems, ultimately cardiovascular function disorder, and ultimately cardiovascular diseases like stroke and angina. And in the fetus that I've already discussed in detail. Now the question arises here, how are we supposed to treat the hypertension? First, there should be regular blood pressure monitoring, and then there are medications to manage the condition. And for each and everything to control the hypertension, the most important thing, the most important intervention is regular blood pressure monitoring. First, we need to identify the problem, and then it comes that we are going to treat it. How to prevent hypertension in pregnancy? That we should encourage the mothers to attend all the scheduled antenatal checkups without any fail, maintain a healthy weight before and during the pregnancy, manage the pre-existing conditions. Like I've already stated, that if there is problems with the mother's kidneys, she is at higher risk. If there is problem with mother being obese, she is at higher risk. So these things needs to be addressed as well. Managing pre-existing conditions like diabetes and obesity before conception, and following a balanced low sodium diet that is rich in fruits, vegetables, and whole grain. There is actually a diet called DASH diet, dietary approaches to stop hypertension, in which there is curtailment of the use of salt, and the diet basically encompasses an increased use of fruits and vegetables and whole grains. If there are any questions, I will be happy to answer those in the end, and I can share the diet plan of DASH diet as well. The other topic that we are going to discuss in this whole presentation is basically obesity and gestational diabetes mellitus. Now, the question is, what is gestational diabetes mellitus? We all know that diabetes in our daily life, what we consider diabetes is that if a person is having more than usual blood sugar levels, that is called diabetes, right? Now, gestational diabetes is something similar to that, but it occurs due to hormonal changes within the mother during the pregnancy, that the mother can be prone to the diabetes, but the inciting factor for the diabetes is basically having that pregnancy. Many mothers, once the pregnancy ends, the diabetes gets resolved, but some may carry it over the years and it is converted into diabetes mellitus type 2. Now, how to identify that the mother has Gestational diabetes mellitus. If the mother has frequent urination, excessive thirst, and excessive tiredness, there are high chances that the mother has gestational diabetes. What we usually say in a medical language lingo, that is, if the mother has polyuria, that is increased urination, polydipsia, that is increased thirst and increased basically demand for water, and polyphagia, that is the mother has increased hunger, then we consider that as primary symptoms for gestational diabetes that can lead to early basically diagnosis of this condition. Now we need to understand what impact does gestational diabetes has both on the mother and the fetus and what the long-term impacts are. The gestational diabetes complications for the mother include high blood pressure that I've already stated, that is hypertension in pregnancy, and how detrimental it is, we have already discussed in detail. The second thing is type 2 diabetes. That is, the mother will develop type 2 diabetes and she will have to live with type 2 diabetes for her whole life. And the third thing is C-section, that due to gestational diabetes, I'm going to discuss in the next slide, that the baby is larger than the size of a normal baby, due to which it almost becomes impossible to deliver the baby via normal vaginal delivery. So the doctor has to opt for C-section wherever necessary. And C-section rates in the mother having gestational diabetes are way higher than in the mothers having no gestational diabetes. This needs to be understood, and this is a matter of great concern, that how gestational diabetes basically impacts the mother. Now the next question arises, how gestational diabetes impacts the baby. The gestational diabetes impacts the baby via preterm labor, that is, the baby is delivered earlier. Birth injuries, the size of the baby is so large that if a vaginal or even a C-section is basically attempted, sometimes the babies get stuck, due to which there are birth injuries. There can be avulsions of the brachial plexus, that is a plexus that runs, nervous plexus that runs from the shoulder in the axilla that connects the girdle with the arm. Moreover, there can be injuries in the neck. There can be fractures like rib fractures, and these birth injuries are a cause of major concern when a mother has gestational diabetes. Another problem that occurs is type 2 diabetes in the baby in the long term. Another concern that we need to understand, if mother has gestational diabetes, then the baby can have low sugars due to passage of the insulin from the mother into the baby. The baby basically has lower sugars as compared to normal babies. It can lead to lower blood sugars in the baby and ultimately fits, seizures, and may also lead to death as well if it is not picked earlier. Moreover, respiratory issues is also one of the major concern in the baby. As I told you earlier about surfactant, surfactant is something that is basically made within the lungs of the baby from 28 to 34 weeks of gestation, and it basically helps the lungs inflate. Now, to inflate the lungs, there is a thing, a liquid that basically lines within the alveoli, within the balloons of the lungs, that helps the lungs to inflate. If the mother has gestational diabetes, this surfactant is lacking. There is basically a problem with formation of this surfactant that ultimately leads to collapse of the lung that ultimately leads to uh, the problems with the respiration, problems with the breathing of the baby, and this is called in our medical lingo respiratory distress syndrome. It can be treated by giving surfactant via outside, via ETT, via invasive method, but the problem lies that there are complications as well. This is a major reason for mortality in children when they are in NICU if the mother has gestational diabetes. So you can understand that how gestational diabetes impacts both the baby and the mother. Now, this is basically a diet that needs to be given to the mothers who are at risk or have gestational diabetes. What we understand from the slides is that gestational diabetes and gestational hypertension both are linked to each other. If we eat food that is basically balanced, that is rich in fiber, that is rich in vegetables, that are rich in fruits, and the foods that have low glycemic index, that the foods that spike up the sugar, we avoid those foods. Only then we can control this issue. So, what foods to avoid? We need to avoid starchy foods such as white bread, white pasta, sugary drinks and foods, junk and processed foods, and high glycemic index foods such as bread and potatoes. We need to switch to better, healthier alternatives. It is important to have small meals throughout the day instead of having one big meal. This ultimately controls the spikes in the sugar level of the blood. So, it is a very important tip for all the pregnant mothers that split your meals and have something to eat every few hours in order to control your blood sugar levels during pregnancy. We have already discussed these things. Now I'm going to just jot it down that how to prevent the gestational diabetes. We need to eat healthy foods. We need to do physical activity. We need to split our meals and eat accordingly. We need to monitor our blood sugar levels, avoid junk foods, drink plenty of water, and maintain a healthy weight. And how is it all possible? That every thing needs to be monitored. And how it can be monitored? Only by good antenatal plan. Only and only by good antenatal visits. If a mother is not following those antenatal visits, if the mother is not basically following the doctor's advice in those antenatal visits, she will not only be impacting herself, she will be impacting her baby as well, and also in the long term, the future generations that we have already discussed. So, what are the aims of antenatal care? To optimize the pregnancy outcomes for women and the babies, to prevent, detect, and manage those factors that adversely affect the health of mother and the baby, to provide advice, reassurance, education, and support to the woman and her family, and to deal with the minor ailments of pregnancy, and to provide the general health screening. So, any problems that are there with the mother are addressed in a timely fashion and in a well oriented manner so that it does not impact both her health and her baby's health. So the risks are not destiny, they are preventable. So we are not delivering babies, we are shaping generations And this leads to end of my presentation. If you guys have any questions, the floor is open for question and answer session, and I will be glad to answer those.
I have a question, and I apologize. There's some construction going on in our building, so if you hear extra noises. Um, One of the areas that I've been concerned about is mothers not receiving their antenatal care. We see here in Duval County that the rate of women delivering with no prenatal care has gone up from about 4% pre-pandemic to 10% after the pandemic. And so we're trying to look at some of the reasons why more and more women are not getting into care. And also, that's just like no prenatal care. And then the ones who go into prenatal care late, and why this has happened kind of post-pandemic in the past few years. So yeah, do you have any ideas about that or comments?
Yes, thank you for your question, Catherine. The basic thing that I can basically uh, understand from your question is that why pre-pandemic there were more antenatal checkups as compared to the post-pandemic. Is that correct? Okay, so if I'm going to answer that in the context of Pakistan, the problems lies with the problem with the economy and the financial problems and the financial burdens that each and every family had to bear pre-pandemic and post-pandemic. Pre-pandemic, the things were more streamlined and there was less financial burden. And post-pandemic, there is more financial problems with each and every person around the world. Secondly, the focus of most things has been shifted to more of intensive care here in Pakistan. The prevention is obviously practiced, but the problem lies that the people do not visit for prevention oftenly. The thing is education. We try to educate the people, but there should be some methodology devised at the level of the governments, at the level of the uh, people for awareness of each and every one so that people can understand the impact that it can have, like this session has been planned. But moreover, the things to visit the hospital must be streamlined as well, be it insurance, be it any other financial assistance, be it logistical assistance. Everything must be monitored and everything must be streamlined. That is the major problem. Once what I have noticed basically that especially antenatal care is poor in far-flung areas. There, even if we educate the people regarding this, the logistical issue is one of the major reasons for this.
I'd like to add some spin on this in context of United States as well, because of the inflation and devaluation and the economic hazards that has happened post pandemic, and the funding cuts and everything, the healthcare provision, sort of things have taken a hit since post pandemic area due to the decreasing economy and the increasing economic burden and stuff like that, and decrease in funding funding cuts, a regular person that used who was previously able to afford the antenatal checkups and who could visit who was insured by his insurer for the regular health visits and checkups is usually not available to do that in the certain scenario. The global scenario of healthcare provision and access is changing monumentously, even though United States has the best uh, healthcare access services and the facilities available, but it's just the disparities among the provision of those resources, that who can tend to avail them and who is not able to avail them.
Thank you so much, Dr. Zoor.
Thank you.
So any more questions are more than welcome. And if you have any queries or any questions that you may encounter late after hearing this presentation, you may contact me on the following email address as well. It has been an honor.
I did have one general question. And of course, you're in Pakistan, but I suspect you're with your connections with Dr. Zahoor, you have some sense of what's happening here, and it's likely could be similar. But where do you see the biggest gaps in our healthcare system when it comes to maternal health?
Being very honest, I have not encountered, or I have not closely been in liaison with US healthcare system regarding the antenatal visits. Since I have already completed my step one and I rotated in few hospitals in US as well. But it was not directly in relation to the antenatal visits. But what Dr. Zahoor has already pointed out, that even in internal medicine rotations, what I noticed is that most of the people visited the health facility after basically having a progression of their disease. That is basically due to financial issues and logistical issues that I've already stated.
Right, right.
And I think that needs to be addressed first. These things needs to be more streamlined, more basically affordable for each and everyone. And thirdly, it is required that the government provides it at a larger scale on more centers, be it the doctors, be it the machinery that is required for scans, be it the tests that are required for antenatal visits. Everything is needed, that is needed, should be provided at a larger scale. For example, there are antenatal visits that can be managed at home as well. If a doctor can visit with a nurse and a paramedic along with the necessary equipment, antenatal visit can be done at home as well. That won't be an issue. It will basically uh, save the family that is expecting a child from such a transition, from going back and forth to the hospital and back to home. And just a single vehicle can carry both the scans and the doctor in charge, and he can go to the home of the mother and can have the antenatal checkup there. Just a good record needs to be maintained and good antenatal care can be provided.
I would like to add some thing to that, because like the maternal health, it used to be considered a basic access for everyone back in the day, but now the landscape is changing towards like uh, pseudoscience. I would have to sadly say that the more focus has been focused towards that, and we just keep on hearing about things that how vaccines do not work at all. So it has kind of started a sort of wave that maybe we do not even actually need specialized visits or antenatal care visits, whether it's for regular checkups or for maternal health checkups. So these disparities are beginning to increase for that as well. Maybe it could be due to that the government or the healthcare providers or the insurers are just trying to save money by reducing that, but it just tends to keep increasing the stem and the gap that just keeps increasing. And even despite having with all of the facilities and available, if you're not putting your fuel into the engine, you're not going to get the output that you desire.
Very, very helpful. If I could turn it slightly, Dr. Hassan, what have you learned, and what has Pakistan learned about this issue that's helped them have a more positive impact?
Uh, in Pakistan, basically, I reside in Islamabad. That is the federal capital. And the province that I reside in is Punjab. In Punjab, basically, they have tried this initiative, not completely successful right now, but there is a slight, uh, you can say, initiative that needs good amount of encouragement. There is initiative by the name of Clinic on Wheels. The things and SOPs are intact, yes, but the functionality can be questioned. It is not functioning in a good way, but the SOPs are very well defined. There are basically in every, what we can say, I don't know what do you refer to that in US. In
Mobile
Pakistan, we
clinics,
refer, no, no,
mobile
I
clinics,
rural clinics,
mobile clinics.
movable clinics. Okay, so we refer to here as clinic on wheels. Each tehsil, you can say each area of around 70 to 80 kilometers square has 6 to 7 vehicles, and 4 vehicles have doctors associated with them that basically goes into different villages, and they note down which woman needs scans, and they check the woman on in their villages in specific locations. Each day the location changes, so there is a larger community that is basically served via this method. And there is one vehicle that has ultrasound attached with it. A radiologist travels in that vehicle, and wherever there is scan required and antenatal visit is required, that specific vehicle moves to that place and performs that scan. So initiative is in place, but yes, the implementation is questionable, and I hope that in few years it will basically evolve and turn into one of the good impact, good you can say steps in healthcare in Pakistan.
Thank you. Go ahead, Dr. Zohar.
Yeah, I think with Jacksonville Urban League, we can also partner. We can make a case regarding mobile clinics or like maternal in regards to maternal health in partnership with the Mayo Clinic grant and the other things that we've been working on. We could also make a case for a policy brief regarding those things, since maternal health disparities exist there as well. So maybe someone in the future cohort can work as well on this policy brief, partnering with maybe Mayo Clinic or Salzbacker or anything like any organization like that, and maybe devising a stuff regarding like mobile clinics so that more people can be able to reach or avail the healthcare services that may not be available to them due to transportation issues and stuff like that.
Mhm. Very good. Good suggestion. Yeah, we're in the process of working on our next phase on this, so that could be very helpful. I know the current mayor is very interested in taking these kinds of approaches, so and her staff as well. Um, we're just 5 minutes before we close, but I did want to say I this was a great presentation because it took us from we've had not only through the program that we've been working on with Mayo Clinic, but in previous sessions we've had a lot of discussion about these issues. But you took us deeply enough into the scientific edge to really make it clear the necessity of taking the kinds of steps that you suggested and making it clear what the problems are. And I would add one more thing. If anyone's interested in seeing the impact of lack of antenatal care, they should watch the season 2 finale of The Pit. It's a series in the United States about an HR where all kinds of things happen. And there's a woman that comes in there who decided that she was going to have a natural pregnancy, didn't want any help from doctors, even a doula. And as a result, she ended up with preeclampsia and had to do a C-section. But it's really, you know, now one has to be, and one of my other thoughts in your what I thought was a brilliant transition from the layperson to the scientific. We do have to be concerned about how we do this in a way that doesn't come off too strong, but at the same time, we've got to get the word out. And certainly, this is one of the goals of the pit. Is they've had numbers of issues that come up where they're making it very clear what's going on in the current environment relative to all kinds of diseases and accidents and what have you that need to be out there for the public. And so I think, Dr. Saur, we should probably, look at this and use it in a way that we can help people transition to better understanding. And yeah, I'll just leave it at that. But I think it's been very, very, very helpful, Dr. Hassan, to us, and we
Thank
really
you.
appreciate it. One of the best presentations I've seen on the issues.
Thank you so much.
Any other
It
questions?
has been a privilege.
Go ahead. What were you going to say, Doctor?
It has been an honor to present this here.
Oh, thank you so much. Well, on behalf of the Urban League, I want to thank you and all those who are attending, and those of you who are watching via YouTube. Be sure and subscribe to the channel because we'll have many more presentations like this, and you can see the others there in the channel. And I'll leave it to Dr. Saur to close us for our presentation.
So this brings a conclusion to our series, one of the series of our maternal health and issue and maternal health and chronic disease prevention. And I would like to welcome I would like to thank all of us, all of the people who joined here and asked their questions and listened to the presentation. It was a really great time for us, and we had a lot of. I think we were able to propagate and disseminate a lot of thoughtful and useful knowledge that the residents and anyone watching this presentation did here. And it is our aim to keep on going with this, and we keep on educating the public and of United States and worldwide. It is our goal and it is our job and mission to do that, and we will keep doing that. And this brings an end to our public town hall. And I would like, on the behalf of Jacksonville Urban League, I would like to thank Dr. Hassan from and Miss Catherine, and there was another person as well, Dr. Miss Bell, I think. And on behalf of Jacksonville Urban League, uh, we are really glad to have you. And I think, and I hope we gave you something really educational stuff that you could all add to your information and knowledge. And we'll see you next time.
Thank you, everyone.
Thank you.